Good afternoon. My name is Anne Marie Silver. I'm Director of Scientific Affairs at Zoll Medical, and I'd like to welcome you to the Zoll Symposium titled Improving Management of TBI and Cardiac Arrest, Training and Technology to Enhance Patient Care. We're delighted to have Dr. Ben Bobrow and paramedic Rasmus Lyngby to present today. I'll begin this presentation with a brief overview of our new TBI dashboard feature on the X Series Advanced, which will lead into Dr. Bobrow's presentation, Pre-Hospital Interventions to Improve Outcomes from Traumatic Brain Injury. Following Dr. Bobrow's presentation, I'll describe our new technology, Real BVM Health, which is also available on the X Series Advanced. Rasmus Lyngby will describe his presentation of real-time ventilation feedback for out-of-hospital cardiac arrest. We'll conclude the session with a Q&A session, and I invite you to submit your questions in the Q&A during the presentation. We'll address them at the end. I'd like to acknowledge all the clinicians who are attending this webinar. Thank you very much for your efforts in fighting on the front line of this pandemic. We wish you health and safety. And we'd like you to complete the poll so we can have an idea of who is attending this session. So if you can indicate your primary clinical responsibility. I'd like to begin by describing the TBI dashboard technology on X Series Advanced. As Dr. Bobrow will describe in his presentation, TBI patients should be carefully managed to prevent secondary brain injury. And this can be achieved through prevention and avoidance of hypoxia, hypotension, and hyperventilation. Zoll has developed a traumatic brain injury dashboard, which contains all the comprehensive information, a comprehensive display of all the relevant information for the treatment of TBI patients in order to avoid hypoxia, hypotension, and hyperventilation. With regard to hypoxia, the lower quadrant of the TBI dashboard features a trend display of the SpO2 numerics. And this allows the clinician to identify when a patient is trending downwards and to intervene before that patient becomes hypoxic. There's a configurable target display here, so you can choose for your system what the appropriate target is. Regarding hypotension, when the user enters TBI dashboard mode, the device is automatically configured to automatic blood pressure interval of every 5 minutes. This is to ensure an adequate number of blood pressure readings are acquired and to really have a meaningful trend in that systolic blood pressure graph here. With regard to hyperventilation, we display a trend of the ETCO2 values, as well as a simple numeric timer, which is a countdown timer that helps you control ventilation rate. So if the target rate is set to 10 breaths per minute, this countdown timer will count down every 6 seconds to prompt the clinician to deliver another breath. This can be paused if ventilations are not required and the patient is breathing spontaneously. CO2 is also prominently displayed as the second waveform, as CO2 is very important during the treatment of TBI patients. I'd now like to hand it over to Dr. Bobrow and just note that the Epic providers actually provided input on this TBI dashboard. And Dr. Bobrow will describe pre-hospital interventions to improve outcomes from traumatic brain injury. Dr. Bobrow is the John P. and Catherine G. McGovern Distinguished Chair for the Department of Emergency Medicine at UT Health in Houston, Texas. Dr. Bobrow is a passionate and skilled clinician, implementation scientist, and leader. We're very pleased to have him today. His efforts are centered on measuring and improving the quality of emergency care and outcomes for patients with time-sensitive conditions, such as traumatic brain injury, cardiac arrest, and acute stroke. Dr. Bobrow's video will be starting shortly. Saskia, are you able to share the video?
To be with you, if not in person, this new medium. I'm an emergency physician, and the title of this talk is Pre-Hospital Interventions to Improve Outcomes from Traumatic Brain Injury. Again, it's a great honor to be with you. I don't have any relevant disclosures outside of the fact that the data I'm going to present and discuss here were funded by the National Institutes of Health. TBI, as many of you know, is a leading cause of death and disability around the world. Over a third of all deaths from injury are related to TBI in Europe. Enormous cost to our countries, and also, sadly, the number one cause of death and disability for children. TBI occurs when there's an external mechanism, usually an acceleration, deceleration to the head, which causes the brain to move inside the cranial vault, very frequently from motor vehicle crash, but also more and more commonly related to falls, particularly with geriatric patients. TBI is also a leading cause of morbidity and mortality on the battlefield. Primary injury, of course, occurs at the time of a trauma, but there is just as much importance to the secondary brain injury, which evolves over the ensuing minutes and hours related to that injury, which is really a cascade of inflammation, ongoing ischemia that's only made worse with repeated episodes of hypoxia, decreased perfusion, and hyperventilation, as we'll discuss. Here's a schematic of what this looks like after the initial primary brain injury. Inflammatory mediators soon set in, which cause significant brain swelling, increased intracranial pressure, decreased cerebral perfusion, and really a negative cycle of worsening brain perfusion, increasing edema, and really what kind of leads to what's often referred to as the death spiral. The early aspects of brain resuscitation are really revolve around mitigating secondary brain injury and avoiding iatrogenic brain injury, which, as I will show you shortly, is incredibly common around these three insults of hypoxia, hypotension, and hyperventilation. Another very interesting concept that some people are starting to investigate is really around early detection and reversal of coagulopathy, particularly in geriatric patients who are on anticoagulants. Sort of the standard paradigm for pre-hospital TBI care really is around immediate stabilization, but rapid transport to the hospital with the goal of getting the patient to the operating suite as quickly as possible. Some people have referred to the main therapy here as high octane fuel to transport patients as quickly as possible. But what this really doesn't look like is what we're used to talking about and thinking about as far as cardiac resuscitation, which really is a timeline where several pre-hospital interventions need to be done. In the case of cardiac arrest, things like immediate CPR, a high-quality CPR to perfuse the brain and heart, followed by early defibrillation. The three insults, again, that are most important and injurious are hypoxia, which occurs commonly. Over half of all patients with severe TBI have some hypoxic episode in the pre-hospital setting. And we know that a single episode of hypoxemia, defined as a non-spurious pulse oximetry less than 90%, is independently associated with at least a doubling of mortality. Hypotension is defined by systolic blood pressure less than 90. Again, we'll talk a little bit about really what is the ideal blood pressure, but sort of the classic the classic thinking is a systolic blood pressure less than 90, which is our current pre-hospital guidelines. If that is violated is associated with the independent, at least doubling of mortality. Hypotension, we know when it occurs, can occur frequently, and we know that in severe blunt TBI, that repeated episodes of hypotension in the pre-hospital setting is associated with a significantly increased odds of death, upward between 3- and 4-fold. The third insult, which is incredibly impactful and common, is hyperventilation. In the pre-hospital setting, we know that somewhere around half of all patients have some hyperventilation iatrogenically performed in the pre-hospital setting. And we know that even some hyperventilation is associated with a doubling of mortality and repeat. There are some studies showing repeat episodes of hyperventilation is associated with up to a 6-fold risk of death. Hyperventilation is common, even in well-trained, well-resourced air ambulance systems. We know that hyperventilation is very, very common and can actually be significant with end-tidal CO2 levels far, far below the recommended range of 30 to 45. We also have lots of data showing that pre-hospital hyperventilation significantly decreases survival rates, and patients who have hyperventilation in the field have been shown to have 77% mortality rates as compared to patients who have no hyperventilation in the field, normal carbia.
While Saskia is correcting this video, please participate in the poll. Thank you.
With both hypotension and hypoxia as opposed to either one individually. So the basic question of our study that I'm going to present was, what is the impact of the pre-hospital TBI guidelines? The Brain Trauma Foundation has had pre-hospital TBI guidelines for nearly 20 years, and no one had really fully implemented these guidelines, and very few people had implemented the guidelines, and no one up until the point of our study had actually quantified the impact of these pre-hospital TBI guidelines on patient outcomes. A more primitive or primordial question that our study was really asking was, does pre-hospital TBI care even matter? Should we have a model where we just load and go as quickly as possible? And is there an impact on patients for doing pre-hospital management of blood pressure, oxygenation, and ventilation? The study I'm going to present is all located on this website, epic.arizona.edu. EPIC is an acronym for Excellence in Pre-Hospital Injury Care. This was a 7-year statewide public health program, which was initiated in conjunction with over 130 EMS systems, 13 trauma centers, and the Arizona Department of Health Services, along with the University of Arizona. Again, you can find all the information, protocols, papers, data are all published on this website. Here's the paper that I'm going to describe, which was formally published in JAMA Surgery in 2019. Really, the purpose of this was to evaluate the impact of implementing these pre-hospital guidelines on a statewide level. Again, this involved over 130 EMS agencies that covered over 90% of the entire 6.6 million population of the state of Arizona. We trained over 600 master trainers who then went on to train and certify over 11,000 active emergency medical technicians across the state. It was roughly 80% of all the EMTs in the state were both trained and certified in the EPIC protocol. We measured over roughly 22,000 moderate and severe TBI cases, 4,000 of which were intubated in the pre-hospital setting. And again, we refer to the 3 H bombs of TBI care as hypoxemia, hypotension, and hyperventilation. This was a before and after system evaluation. By design, this was not a randomized study. We did not feel that randomizing these guidelines, although they had not been implemented across the state or measured, we did not feel that randomizing these guidelines would be ethical. So we did what we believe was the next best way to study the impact of these guidelines, which was a well-controlled, very well measured implementation study. We abstracted TBI data on roughly 36,000 patient care reports and used the Arizona State Trauma Registry, an extant, mature state trauma registry, and we linked over 98% of all the cases in our study were linked between pre-hospital and hospital data. This was far orders of magnitude more than any other similar project or studies had been able to do prior to this. Our EPIC inclusion criteria were a CDC Burrell matrix score of 1 or an acute injury score ahead 3 or more. We included moderate, severe, and critical TBI patients, and this was actually not defined, specifically intentionally not defined by their GCS estimated by pre-hospital providers, but was instead defined by trauma registry data, and this allowed us to exclude. This prevented us from excluding true TBI patients or inadvertently including non-TBI patients that appeared to have TBI, such as intoxicated patients and so forth. And this was really unique in EMS TBI evaluation. Our protocol really was founded on prevention, immediate recognition, and urgent reversal of hypoxia. And so our protocol called for immediate application of high flow oxygen on all TBI patients. And so one of the ideas is that we did not want to wait for them to become hypoxic. We pre-oxygenated them. And our belief was that a period of high flow oxygen in the pre-hospital setting, which is usually around 10 to 15 minutes, would not be harmful, and we did not find it to be harmful. If patients were hypoxic when they had high flow oxygen applied, then they received some positive pressure ventilation at a rate of 10 breaths per minute, and endotracheal intubation or advanced airway management only when the BVM was inadequate or there was a high risk of aspiration, or we had patients who were going to be transported by helicopter. As far as hypotension, we used the threshold of 90, but really our training revolved around not just avoiding blood pressure, systolic blood pressure less than 90, but not even letting the blood pressure dip just under it. So if patients, in other words, were trending, the blood pressure was trending down, our protocol directed pre-hospital providers to administer IV crystalloid therapy in 1,000 milliliter initial bolus followed by 500 milliliter bolus until the blood pressure was improved. We did not utilize any pressors in the pre-hospital setting, and for children, we used 30 cc per kilo crystalloid boluses. The EPIC treatment protocol for hyperventilation was based on target ventilation rates for age that you see here, but was really targeting end-tidal CO2. So one of the main improvements we believe was that our systems now during the EPIC study, if they were going to do advanced airway management, having end-tidal CO2 was a requirement. And prior to that, some systems would manage patients' airways without continuous capnography. We also, as part of our treatment and training, was having a unique ventilation EMT who their job was specifically to monitor the ventilation, monitor the end-tidal CO2, so that all the other providers on the team could continue to do their roles and treat patients. But there was one person specifically designated to monitor the ventilation to avoid hyperventilation. We gave this role a special importance. In our study, there were 21,852 patients that met inclusion criteria, 15,000 in the pre-implementation, and over 6,000 in the post-implementation period. Our overall study included moderate, severe, and critical TBI patients based on their acute injury severity score. And you can see here that the majority were in the severe TBI group with AIS scores of 3 to 4. We do know that we did have a significant impact on patient care. We measured in our after implementation group, our P3 group, we measured a significantly lower rate of endotracheal intubation, despite the fact that in our post-intervention group, we had much sicker patients. We also measured a much higher rate of reversal of hypoxia prior to arrival at the trauma center, a much greater likelihood of receiving IV fluids, any IV fluids, if patients were hypotensive or becoming hypotensive, and a higher volume of IV fluids for those patients prior to arrival at the trauma center. And also we measured a significantly lower rate of hyperventilation in intubated patients and patients receiving any kind of positive pressure ventilation. So for our overall results, we had an adjusted odds ratio overall for survival to hospital discharge of 1.06, which did cross 0 with a p-value of 0.4. We found an adjusted odds ratio of 1.70, which was significant for survival to hospital admission. What I want to point out is that nothing in our trial had anything to do with treatment once patients arrived at the hospital. So whatever was going to happen to them happened the same throughout the course of our study. And so we believe the fact that we did measure a significant change in survival to hospital admission, but not a significant change in survival to hospital discharge may have been related to that, because we definitely saw the same type of hospital care happening after arrival. But again, our study was really focused on the pre-hospital aspect of care. We had a secondary planned analysis to look at the impact of survival in specific injury categories. And I'd like to review a few of these. One is that what we found is in the head injury severity score group of 3 to 4. So really our severe but not critical group, we had a more than twofold higher survival to hospital discharge in the post-implementation group. Likewise, in the group which had a head injury severity score of 3 to 4, but received any positive pressure ventilation, both a bag valve mask ventilation or advanced airway, there was an adjusted odds ratio of 3.5 for improved survival to hospital discharge. The overall kind of one snapshot slide of the study that was that JAMA developed for this was really that patients who had severe TBI had more than a doubling in odds of survival to hospital discharge, and if they were intubated severe, they had over a threefold improvement in survival to hospital discharge. So while the entire cohort of patients, the minimally injured and the critical overall did not show an improved survival hospital discharge, perhaps the ones that we really had the best chance of helping and the best opportunity to see some change in severe TBI patients did have a doubling of survival. So that was really our conclusion for this statewide trial, again, involving more or nearly 22,000 TBI patients, roughly 4,000 of which were intubated prior to arrival at the hospital. Some other interesting data that's come out of our study was really we had the opportunity while we were doing this trial to look at things like thresholds, specifically around blood pressure. And as I mentioned before, that blood pressure, systolic blood pressure of 90 has really become sort of the holy grail, the mantra that we should not let patients' blood pressures drop below 90. But what we found in our data of over 15,000 patients was that there really was no detectable inflection point, no steep drop-off of survival at 90, or as you see on the curve, or at 100 or 110. In fact, the optimal systolic blood pressure may be even greater than 110 or 120. And so we're hoping to design and implement some randomized trials to look at that very question. We also looked at the impact of depth and duration of things like hypoxia, and we're doing analyses of depth and duration of hypotension and also hyperventilation, with the idea that, our measurements have been very crude up until now, really just measuring one episode of any of these insults. But what if there were multiple episodes or there were prolonged episodes? And so really we have been doing detailed analyses looking at this concept of depth and duration on traumatic brain injury. So a couple of things I want to highlight from this, and I hope that these will be take-home messages. One is that, the beauty of focusing on these three H-bombs, hypoxia, hypotension, and hyperventilation, is that they are simple. While they're simple, they're not easy to manage on a system-wide basis. They do not require $1 billion drug, and emergency providers have the technology and the training to do these things. The real issue is doing them well. And what I want to stress is this is not just an issue in the pre-hospital setting. This is an issue in the hospital. I'm an emergency physician, and I see this continuously, that we mismanage patients, and we end up either intentionally or inadvertently violating these three areas of hypotension, hyperventilation, and hypoxia. And that if we were much more attentive and really rigorously implemented these measures, we could help many more patients. Number two is that when you start to focus on the neuron as opposed to just getting patients to the hospital, it really changes the paradigm. With the neuron, we know that apoptosis begins after only just a few minutes of hypoxia or hypoperfusion. So this really blasts the concept of the trauma golden hour out of the water, where an hour is far, far too long for TBI. 30 minutes is far, far too long for TBI. If we're thinking about the neuron, really focusing on the neuron in traumatic brain injury, the timeline appears to be much, much more like that cardiac resuscitation timeline that we showed, where we know we have just a few minutes to start CPR, to initiate heart and brain perfusion, and then to make interventions to correct the correct the state of cardiac arrest. If we think about TBI like that, we really are thinking minutes, in which case it leads us to really think about the pre-hospital, the importance of the pre-hospital aspect of care, which is really not maximized with simply a rapid load and go strategy. Number three, healthcare providers get distracted. We all get distracted. EMTs in the field understandably get distracted. They have many things and situations to manage simultaneously. We saw that our training was taken up very well, and we made huge strides in the first 18 months or so. But then we saw significant deterioration in compliance, and we had to do repeat training. And it's really just really human nature that things fade quickly, and people begin to revert back to what they initially were initially taught and what they used to do. And so without a constant vigilance and feedback system to providers, this distraction with distractors, they just fall back into these old habits. And again, it happens inside the hospital and outside the hospital. And it really begs the question of how do we develop these feedback loops and systems to continuously help providers measure and improve these aspects of TBI care. And finally, the real baseline question of, does TBI care even matter? What we believe, our study showed that, in fact, pre-hospital care does matter. And in fact, it may be what matters the most. Our old model of just getting patients to the hospital as fast as possible so they can get to the operating room really has had very, very modest impact on TBI outcomes. In fact, many have argued no significant improvements in several decades. We showed a doubling in survival for victims with TBI, which is a major public health problem. That is a huge leap forward. That is a major, major improvement. And what we believe is that our biggest opportunity now is, how do we implement these systems in a rigorous way? How do we continuously measure and improve these metrics of ventilation, blood pressure, and oxygenation, but really in a system of care paradigm from the time we interact with a patient until the time that they're in the operating room? How can we do this as carefully and completely as possible? I did have the great honor of seeing the impact of this work on several patients during the time of our study. Here, I would just like to show you a young child that was involved in our trial. Early in the trial, you can see that the car, he was actually a restrained passenger in the back seat of that car, which was horrifically damaged. You see there, and he had a severe traumatic brain injury, was quite sick in intensive care unit. And at the end of our study, nearly 6 years later, we had the great honor of meeting this young gentleman and his mother, who you can see there in the back. She actually, interestingly, is a firefighter paramedic in Arizona, was part of our trial as well. And you can see the young gentleman, he had a very, very good appetite, and I'm pretty sure he got a lot of that chocolate on our close that day. But it was a great honor to meet him and his mom, and it was just wonderful. So having the ability to see the impact of this was really the best part. I want to thank you for your time. Thank you for the invitation to participate in ERC 2020. I hope to be with you in person in 2021. That would be a wonderful, wonderful thing. And I would like to really give a very, very sincere thanks to Dr. Anne-Marie Silver and her research team at Zoll Medical. Dr. Silver had worked with us throughout the course of the EPIC TBI trial and helping us design systems and technology that could help measure this TBI care. And it was absolutely instrumental, and we're very, very grateful to Dr. Silver and her team. Thank you so much, everyone. Hoping that you stay safe, and best wishes during ERC 2020. Bye-bye.
Thank you, Dr. Bobrow, for an excellent presentation and educating all of us on the importance of managing patients with TBI very carefully. I quickly resume share my screen. Okay, I'd like to report the results of the polls. Thank you for all who participated. For the first poll about the clinical responsibilities of participants, 35% had primarily hospital responsibilities, 31% pre-hospital, 15% a combination of both, and 23% non-clinical. And for the second poll, when the participants were asked about their level of focus on TBI training and guideline adherence in their system, 14% reported no focus, 38% minimum attention, 35% medium attention, and 14% substantial attention. I think Dr. Bobrow has given us insight into the importance of paying close attention to these TBI patients. So thank you very much, Dr. Bobrow. I invite the attendees to enter their questions into the Q&A, and Dr. Bobrow will address those questions at the end of this session. I'd like to move on now to describing the Real BVM Help technology, real-time ventilation feedback on the X Series Advanced. The impetus for us developing real-time ventilation feedback was really our real-time chest compression feedback. With our chest compression feedback, we can monitor and provide real-time feedback on the depth, rate, and release of compressions, as well as an interval timer to organize resuscitations. Dr. Bobrow conducted a pre-hospital study with this technology and demonstrated that use of this technology along with scenario-based training led to improved CPR quality, increased survival. In fact, the odds of survival increased 2.7-fold in the second phase, and favorable functional outcomes. But we realized that cardiopulmonary resuscitation incorporates both chest compressions and ventilations. So we wanted to address the need for ventilation feedback. We developed the real-time ventilation feedback, Real BVM Help. The technology includes a disposable flow sensor that's placed in line in the airway circuit between either the mask and the bag or the endotracheal tube and the bag. There's also a reusable cable component that connects to this disposable sensor. The Real BVM Help dashboard displays a breath-by-breath report of the volume and rate of ventilations, as well as a ventilation quality indicator, which Rasmus will describe in detail. Just want to briefly orient you to it. This ventilation quality indicator fills in real time as you deliver a breath. And once the target tidal volume, which is configurable, is hit, that circle is filled and the rescuer is prompt to stop ventilation. If the ventilation was in target for volume and rate, the circle will be colored green. If either of these parameters were out of range, the circle will be colored yellow, and the corresponding numeric will be colored yellow as well. Then a countdown timer is displayed so the rescuer can anticipate when the next breath should be delivered. A rescuer can really focus on the ventilation quality indicator and just look quickly at the volume or rate if one of those parameters was out of target. Real BVM Help can be incorporated with the CPR dashboard. So when chest compressions are detected and a ventilation is detected, the two dashboards will be displayed side by side. And the configured target rate for CPR specifically will be displayed for Real BVM Help. For example, if your system begins with 30 to 2 ventilations, we can configure the 30 to 2 as the default. Whereas if you start with continuous ventilations, the device can be configured for 10 breaths per minute, and the countdown timer will be enabled. The Real BVM Help dashboard is also integrated into the TBI dashboard when ventilations are detected during the delivery of therapy to a TBI patient. I'd like to now introduce Rasmus Lyngby, who will describe real-time ventilation feedback for out-of-hospital cardiac arrest. Rasmus is a critical care and tactical paramedic at Copenhagen EMS and a doctoral student at Kingston University in London. He's investigating the use of real-time feedback for out-of-hospital cardiac arrest patients. He's worked as a paramedic for the past 13 years, We really appreciate his participation in this symposium. And I invite you during his session to complete the poll that we will display. Thank you, Rasmus.
Thank you to Zoll for the invitation to speak and for hosting this symposium despite the circumstances. For the next 15 minutes, I'll be talking a bit about the challenges of manual ventilation in the pre-hospital setting. I'll present the results from a randomized controlled simulation trial on real-time ventilation feedback, and then talk a bit about the future of real-time feedback in EMS. First up is the challenges in manual ventilation for EMS. Not that many papers have investigated the challenges faced by ambulance technicians and paramedics when performing manual ventilation with a BVM. Papers have concluded that we tend to hyperventilate patients, which may be harmful, but the reason that actually leads to that performance remains largely uninvestigated. Few papers have mentioned that some of the factors that may contribute to the challenges of performing correct ventilations. Looking at EMS, we often work in an uncontrolled environment where focus may be challenged by having to pay attention to surroundings or having to pay a lot of attention to our own safety, which may lead to less focus on the task at hand and performing ventilations. The limited resources available to us in combination with the advanced procedures and the need to perform many tasks simultaneously may also contribute to the lack of guideline adherent manual ventilations. Finally, despite several years of pre-hospital experience, a paramedic may simply not be exposed to the number of patients requiring manual ventilation for him to ever gain routine in doing so. At Copenhagen EMS, we handled around 120,000 emergency calls each year, and only 1% of those are cardiac arrests. An Australian study found that the median exposure to out-of-hospital cardiac arrest for a paramedic was 2 events per year. This argues for a lack of routine despite having spent several years working in EMS. All these factors are the reason why we should consider real-time feedback as a tool that might improve our practice. To face these challenges, Copenhagen EMS and Zoll conducted a simulation study investigating the use of real-time ventilation feedback. We recognize out-of-hospital cardiac arrest as a worldwide health problem affecting close to 700,000 people in the USA and Europe each year. Fewer than 15% of those treated by EMS survive to hospital discharge. CPR is essential to survival from out-of-hospital cardiac arrest. In addition to high-quality chest compressions, ventilations must be delivered to the patient at an appropriate rate and volume to optimize the flow of oxygenated blood to the vital organs and avoid impairing intrathoracic pressure. Myocardial perfusion, cardiac output, and blood flow to the brain have all been shown to decline with hyperventilation, while cerebral and coronary perfusion pressure significantly increases when ventilation rates are reduced. This study investigates whether real-time visual ventilation feedback improves manual ventilation quality during resuscitation in a simulated cardiac arrest scenario using a novel flow sensor technology. We hypothesize that the use of real-time ventilation feedback during CPR will improve ventilation quality delivered by the pre-hospital providers in a simulated out-of-hospital cardiac arrest setting. We conducted a non-blinded randomized simulation trial enrolling 64 on-duty paramedics serving within Copenhagen EMS. Participants were allocated one-to-one to either real-time ventilation feedback or no ventilation feedback 32 participants in each arm. After a standardized introduction, crews were conducting an 8-minute simulated out-of-hospital cardiac arrest, shifting positions between ventilations and chest compressions every 2 minutes. Manual ventilation quality was measured using a Zoll X-series defibrillator equipped with a differential pressure sensor, the AccuVent, attached between the bag and the ET tube. The ventilation feedback dashboard features a breath-by-breath numerical value for ventilation rate, that's breath per minute. It's seen to the right, and a tidal volume in milliliters seen to the left. A countdown timer and a ventilation quality indicator is seen in the middle. Numerics for ventilations delivered with a specified target range are displayed in green, while ventilations outside of target range are displayed in yellow. The countdown timer is positioned inside the ventilation quality indicator, which counts down to prompt the user to deliver a breath base on target. When a breath is delivered, the quality indicator will gradually fill until the target volume is reached. Then the graphics will change to green if both numerics are in target, or yellow if one or both are out of target. The result from our simulation trial. The ERC guidelines recommend a tidal volume of 500 to 600 milliliters for each ventilation. We found that compliance with guideline recommendations for tidal volume reached 43.5% for the control group. The intervention group reached a compliance of 75.1% for tidal volume. On ventilation rate, the target range are displayed in green, while ventilations outside of target range are displayed in yellow. The countdown timer is positioned inside the ventilation quality indicator, which counts down to prompt the user to deliver a breath base on target. When a breath is delivered, the quality indicator will gradually fill until the target volume is reached. Then the graphics will change to green if both numerics are in target, or yellow if one or both are out of target. The result from our simulation trial. The ERC guidelines recommend a tidal volume of 500 to 600 milliliters for each ventilation. We found that compliance with guideline recommendations for tidal volume reached 43.5% for the control group. The intervention group reached a compliance of 75.1% for tidal volume. On ventilation rate, the ERC guidelines recommends a rate of 10 breaths per minute for an intubated patient. We found that compliance with guideline recommendations for ventilation rate reached 57.8% for the control group. The intervention group reached a compliance of 95.2% for ventilation rate. When combining correct tidal volume and correct rate delivered simultaneously, we found that the control group performed correct ventilations in 24.5% of the delivered ventilations, compared to 72.5% delivered by the intervention group. When controlling for participant covariates, adherence to ventilation guidelines was 45.5% higher in participants receiving ventilation feedback. Real-time ventilation feedback, or we concluded that real-time ventilation feedback increased guideline compliance with both ventilation rate and tidal volume in the simulated out-of-hospital cardiac arrest setting. Real-time feedback has the potential to improve manual ventilation quality and may also allow providers to avoid harmful hyperventilation during out-of-hospital cardiac arrest. So, looking at the future for real-time feedback in EMS, not only ventilation feedback, but chest compression and ventilation feedback as a whole. The technology was first introduced about nearly 20 years ago. However, it remains sparsely investigated. Since 2010, not more than 5 to 8 studies have investigated the use of the technology, so the potential of real-time feedback is yet to be fully discovered. There's also a great potential for further development of the technology. At the moment, we primarily use performance feedback. That's feedback on that's feedback on the things we do to the patient. However, we must recognize that CPR is a one-size-fits-all procedure. And if we're capable of developing real-time feedback that actually feeds back on physiological, provides physiological feedback for the paramedics, that's feedback based on how the patient reacts to our treatment, I believe that we might see a significant jump in out-of-hospital cardiac arrest survival. So moving from performance feedback to physiological feedback is definitely worth investigating, and also further development of the technology. Despite the potential, we must also not forget the limitations in the use of real-time feedback. We always teach our paramedics to treat the patient and not the monitor. Now we have to unlearn that mantra and learn and teach them how to treat the monitor instead of the patient. We also need to teach them to trust the monitor and trust the values that the monitor gives them during CPR. At the same time, we must also teach them the limitations of the technology, enabling them to navigate in when to use the feedback on the screen, on the monitor, and when to deviate from that information and actually treat the patient and not the monitor instead. So teaching paramedics to navigate and use the clinical judgment and when not to use the clinical judgment is definitely also a challenge for using real-time ventilation feedback. This was all I had to share with you guys. Thank you very much for listening. And again, thanks for having me.
Thank you, Rasmus, for a terrific presentation. As a reminder, please enter your questions into the Q&A section, and we will address those now as we open up the Q&A session. I'd like to report on the results of the poll. We had 48% of participants reported that they believe clinicians perform manual ventilation poorly in their system, and 48% moderate. Only 3% believe ventilation is performed well and 0% excellent. So it seems like there's opportunity for improvement there. All right, so now to address questions in the Q&A. A couple of them are related to the technology that I'll quickly address. So one was about how easily you can switch between 32 and 10 breaths per minute setting for ventilation target rate. And we're following the user interface of the X series that you navigate to that parameter and select it to adjust the setting. So it's the similar UI that X series users are accustomed to. And there's also a question around whether that we've demonstrated improvements in ROSC or survival rate with use of real BVM help. Because this technology is new, clinical studies have not been conducted, but they are planned. So we'll have to get back to you on that question. And so I guess this question is for Rasmus. There was a question of whether you would add ventilation feedback to your service.
I would definitely recommend that my service would use the real-time feedback. Of course, we need to, from my perspective, it would be great to do it as a clinical trial, but I would have no doubts that it would improve the patient care that we deliver. No doubts at all.
Thank you. So a question for Dr. Bobrow. You mentioned that performance declined throughout the study, and obviously it must be challenging to train 11,000 providers and to conduct refresher training. Curious about how frequently you believe refresher training should be required, and I guess the logistics around how you actually accomplish that with such a large pool of providers.
Yeah, it's a great question. We did see really quick, relatively quick drop off in proficiency, and it's not surprising. I think Rasmus even showed that, with cardiac arrest, the majority of pre-hospital providers in most places, it's not the same everywhere, but in most places do relatively few. I think Rasmus showed two resuscitations a year, and TBI, it can be, along the same line. So, performance and really proficiency drop off quickly. We tried to use, since our model was a statewide model, again, we were working with thousands of people. We used a train the trainer model, and we tried to do every 6-month training, retraining. That was our goal. It was very, very difficult and challenging to do. But we used a lot of web-based training, and that's how we tried to reach people. But again, it was a huge challenge, and we see it everywhere. I see it inside the hospital as well. We have huge opportunities, but people get distracted. We just have a lot going on, and particularly around ventilation and blood pressure management, we really need, I believe, some real-time tools and triggers to help us stay on track.
Thank you, Ben. A question for Rasmus. How much training was required for the participants of the study to become proficient in use of real BVM help?
Well, the paramedics were all taken from the daily service, so they are used to using the X series. They are familiar with the feedback dashboard. They had 5 to 6 minutes of training and introduction to the system, to the dashboard, and then they kind of adapted. They were very quick to get the feeling of how the technology actually worked, but they were familiar with the feedback dashboard for chest compressions. And it does look the same. If you need to train for first the feedback dashboard for chest compressions, you would need additional time. But if they are familiar with the real BVM, the chest compression dashboard, the real BVM doesn't seem to require more than a few minutes.
Thank you. All right, and finally for Ben, what do you think can be done to move the needle on survival for the critically injured TBI patients?
As I said, I believe that pre-hospital care makes a huge difference, maybe is the biggest opportunity that we have to improve survival rates for traumatic brain injury, and that would be a big deal. There's very few things in medicine that you can show can double your odds of survival, and this what we showed was this actually can double your odds of survival. But it's not an expensive drug. It's really something that's right in front of us, and it just takes sort of rethinking these things, and it does take some planning and how do you operationalize these things. But I really believe that we have this opportunity right in front of us, and I do think that more and more people are seeing this opportunity and are taking the opportunity. And my hope is that it really becomes ubiquitous, that we measure and improve oxygenation and ventilation and blood pressure management throughout the entire course of someone's resuscitation, from the time they're injured all the way to they get to the operating suite.
Thank you. Okay, so that concludes our session. I'd like to thank all the attendees. And if you'd like to learn more about the X-Series Advanced, the features TBI dashboard, Real BVM Help, please visit the Zoll virtual booth. And you can enter the code displayed here if you want to enter for a chance to donate an AED to a charity of your choice. I've added my contact information. Please reach out to me if you have questions. You can also ask questions on Slido, and we will continue to address those questions, or to enter the Zoom room. Thank you all for attending.